Hello, my name is Luke. Welcome to my presentation on distributive shock secondary to anaphylaxis. In this presentation, we will look through the pathophysiology, clinical features, physical examination, some relevant investigations, pharmacologically and management of distributive shock and anaphylaxis, as well as leadership roles as they apply to this situation. So firstly, some learning outcomes. We will familiarise ourselves with the management for distributive shock and anaphylaxis as available to out-of-hospital clinicians. We will enhance decision-making in the field and promote teamwork. So some definitions. Distributive shock. It is excessive vasodilation causing impaired blood flow and perfusion. Etiologies include sepsis, anaphylaxis, as well as neurological. So, in order to discuss distributive shock during anaphylaxis, first we must delve into anaphylaxis itself. Anaphylaxis is a severe immunologic reaction, with most reactions occurring through an immunological pathway referred to as immunoglobulin E, or IgE mediated. Less commonly, it may be the result of non-immunological mechanisms. These may include psychogenic types, or where mediators are released via exposures such as heat and cold. Reactions can occur when an individual is exposed to an allergen, for example, some medications, foods, or toxins like a bee sting. Hypersensitivity develops and occurs when granulocytes, which are a type of white blood cell, are primed by IgE after an initial exposure to an allergen. Patients with known allergies actually have higher concentrations of IgE and inflammatory mediators. So when those granulocytes that are primed with IgE antibodies are then re-exposed to that allergen, degranulation occurs. There is then the subsequent release of inflammatory mediators. IgE then activates mast cells and basophils, which in turn activates histamine and other inflammatory mediators, such as cytokines and prostaglandins. Histamine is an important factor in this process as it contributes to bronchoconstriction, arrhythmia, and as a neurotransmitter stimulates vomiting. Significantly, it can also signal nitric oxide secretion. This causes excessive vasodilation. This vasodilation causes the endothelial barrier to destabilize, leading to increased capillary permeability and extravasation. The consequence of this is massive fluid shift, which can contribute to airway edema and hemodynamic instability, and ultimately anaphylactic shock. In cases of severe anaphylaxis, up to 1/3 of the circulating volume can leak out within minutes. Severe reactions can occur with a delay in adrenaline administration, as these inflammatory mediators continue to release unopposed, and can also occur as a result of the anaphylactic process. So, clinical features and some physical examinations to perform through distributive shock. Clinical features of distributive shock secondary to anaphylaxis can present a myriad of symptoms, as patients with distributive shock may experience signs of poor perfusion with altered mental status, tachycardia, hypotension, tachypnea, hypoxia with low oxygen saturations reflected, poor capillary refill, and relative hypovolemia. Patients may also experience hyperthermia, and warm extremities secondary to that massive peripheral vasodilation. Importantly, shock, particularly in early stages, may go unrecognized in anaphylactic patients, as these patients may already be experiencing signs and symptoms of shock. Some two classic ones are tachycardia and tachypnea, for example. So, a known history of allergic reaction, anaphylaxis, or allergies, with an acute onset of symptoms, may help to suggest potential causes for shock. Where patients are experiencing distributive shock, secondary to anaphylaxis, they may also be experiencing other signs and symptoms associated with anaphylaxis as seen in this image. So a wide array of symptoms, signs that are affecting multiple body systems. Importantly, for distributive shock, we can see hypotension, tachycardia, vasodilation with increased vascular permeability, syncope. There is also hypoxia associated with shock. Unfortunately, angioedema and bronchoconstriction, as part of these anaphylactic processes, will also contribute and worsen this. So some relevant investigations. As part of our airway assessment, we must consider the potential for airway obstruction and consistently reassess. This is particularly important as these patients may experience angioedema as part of that fluid shift. Considering the Mallampati score as a predictor for a difficult airway may also help with trends as well. As part of the respiratory assessment, auscultation can determine the presence of bronchospasm and include and exclude differentials. For instance, the causes of tachypnea, whether it's as a result of shock, that bronchospasm, potentially even both. Capnography can provide real-time feedback and monitoring. It can reflect bronchospasm, and a low end-tidal CO2 is also suggestive of shock. Cardiac monitoring is important as anaphylactic processes, as well as adrenaline, can lead to hemodynamic instability and arrhythmias. ECGs may also be used to rule out other causes of shock, such as cardiogenic. Anaphylaxis can be treated based on clinical presentation. Point-of-care testing does not offer further value in this case, and as such, investigations should never delay the early administration of adrenaline. So, pharmacology and treatment. With adrenaline, adrenaline is the only proven pharmacological intervention that reduces the effects of anaphylaxis. Similarly, and importantly, it is also used in the treatment of distributive shock. Adrenaline activates alpha and beta receptors, which work to reduce the symptoms of anaphylaxis and reverse the effects of IgE-mediated reactions. It suppresses leukotriene and histamine release from mast cells, which would otherwise increase that vascular permeability and continue inflammatory processes that worsen and lead to distributive shock. As such, early administration is critical to reduce severity of symptoms, with delayed adrenaline associated with increased mortality. Delayed adrenaline is also associated with increased risk for biphasic reactions. So, adrenaline decreases airway obstruction through activation of alpha receptors, which decrease mucosal production, and through beta receptors that lead to bronchodilation. Whilst working to reverse those inflammatory processes, adrenaline also treats hypotension through increasing systemic vascular resistance, increasing inotropy and chronotropy, and thus improves cardiac output and stabilizes vascular permeability. Essential. The adult dose for intramuscular adrenaline is 500 micrograms, with the pediatric dose being 10 micrograms per kilo for a max dose of 300 micrograms. Refractory anaphylaxis can occur when there is an appropriate fluid resuscitation and 3 dosages of intramuscular adrenaline do not remedy hypotension or symptoms. It may be used as an IV infusion vasopressor at a rate of 5 micrograms to 50 micrograms per minute, titrating to a MAP of 65. This is critical as this is our main treatment for treating that distributive shock. Where an infusion is not set up, or in cases of rapid deterioration, IV boluses of 50 micrograms to 100 micrograms can also be used. Some adverse effects for adrenaline include anxiety, hypertension, cerebral vascular accidents, cardiac arrhythmias, and ischemia. The risk for these are increased when given intravenously or at incorrect dosages. So with all this, we're trying to optimize ventilation and oxygenation, with hypoxia being the most common cause for cardiac arrest. Shock is when oxygen delivery cannot meet demand. So we must address some anaphylactic processes that further impair this. Angioedema can obstruct the airway, with nebulized adrenaline potentially reducing this risk. As we explored earlier, it also reduces mucosal production. Supplemental oxygen is essential to addressing hypoxia, particularly in the context of shock. Interestingly, recent data is suggesting that salbutamol may have a wider role in anaphylactic processes. So salbutamol should obviously be used in patients experiencing bronchospasm. However, salbutamol improves ventilation and reduces intrathoracic pressure, which can also assist with venous return. As a beta-2 agonist, salbutamol may also inhibit the release of inflammatory mediators, and it can be used both nebulized and intravenously. So these interventions, particularly those that address airway and breathing, but as well as supplemental oxygen, salbutamol may also assist in combating the features of shock. So glucagon. Where anaphylaxis is refractory to adrenaline, glucagon should be considered. Similarly, glucagon should also be considered in patients using beta blockers, as adrenaline will obviously be less effective in those patients. Glucagon bypasses beta receptors and increases cyclic AMP, which in turn increases inotropy and chronotropy. Patients who are beta blocked, or those that are refractory to adrenaline, are more likely to experience bradycardia, increased vagal tone, and continued inflammatory release. In these instances, glucagon is linked with improved hemodynamics. However, a secure airway is essential when administering glucagon, as it is associated with vomiting. Glucagon dosages should also be considered at 1 to 2 milligrams. So crystalloids, sodium chloride 0.9%. Aggressive fluid management is necessary in these patients, as we've explored the anaphylactic process leads to systemic vasodilation. So we can provide up to 1 to 2 liters of isotonic fluids, or 20 ml per kilo, for both adult and pediatric patients. Patients typically will respond well to these boluses, but we must also consider the potential for overload and acidosis. As mentioned earlier, appropriate fluid management is critical in assessing whether or not refractory anaphylaxis is occurring. So antihistamines, theoretically, they should work. However, there is little evidence to suggest that antihistamines are effective in the management of acute anaphylaxis. Antihistamines have no impact on the prevention or treatment of upper airway obstruction or circulatory collapse. Oral antihistamines best treat symptoms affecting the skin and are considered a second-line treatment. Similarly, hydrocortisone and other corticosteroids, their use in anaphylaxis is purely theoretical. They are believed to reduce reaction and their severity through reducing the production of inflammatory cytokines and inflammatory mediators. It is considered a second-line treatment as they do not prevent or treat upper airway obstruction, hypertension, or shock. For hydrocortisone, the maximum serum concentration time is 1 to 2 hours, with other corticosteroids being between 4 to 6. It is possible that hydrocortisone and corticosteroids may prevent biphasic reactions. but the current data does not support, nor does it refute this. It's possible that corticosteroids may benefit patients with a past medical history of asthma or other ongoing respiratory symptoms. It's important, though, that the administration of corticosteroids should never delay the administration of adrenaline. So some general considerations here. Airway management. Be vigilant for upper airway obstruction, vomiting, and the need for airway adjuncts, particularly as fluid shift will contribute to both shock and angioedema. They may be seen at the same time. Patients should be positioned supine to assist with cerebral and cardiac perfusion, as standing is linked with cardiac arrest. Treat other symptoms associated with anaphylaxis, such as angioedema and bronchospasm, particularly as this will be in the context of shock. We don't want to worsen hypoxia. Adrenaline is the only drug proven to treat anaphylaxis, and for distributive shock, it can be used alongside fluids as a vasopressor. This is despite some of the theoretical benefits to some of the explored pharmacal options. So here we have a summary for treating anaphylactic shock. You can see here that adrenaline, sodium chloride, and glucagon. So our transport decision making. Anaphylactic patients experiencing distributive shock will likely require intensive care support. Hospitals that offer these services are going to be desired. However, we must consider the patency and protection of the patient's airway, particularly where loss is suspected within the context of angioedema and or stridor, and where respiratory distress is present. Airway adjuncts may be necessary, particularly intubation, that may even need to be facilitated through rapid sequence induction. In this instance, where other pre-hospital resources are unavailable, the closest emergency department is appropriate. And of course, urgent transport is a priority. So, with this transport decision making, it will largely revolve around how comfortable you are to safely transport this patient based in the area in which you work. You must consider the availability of specialist skills and resources, such as medical retrieval. Consider the availability of other crews to provide support. Importantly, consider the patient's resistance to appropriate treatment. If you cannot safely transport the patient to a more advanced hospital, consider the closest. This will be particularly relevant for refractory anaphylaxis or those who aren't responding to your treatment. Consider the concerns of attending clinicians and address them appropriately when making these decisions. System leadership roles. Leadership roles within a complex scene can take on many forms. The obvious examples are those providing some clinical leadership, but it can also be individuals organizing logistics, such as extrication, bags, etc. Those performing specialist skills and administering certain drugs, whether performing them themselves or overseeing them. Importantly, there is a need to recognize the need to request for help. Extra crews increases situational awareness and allows for delegation. Crew resource management is critical here, particularly in the case of distributive shock. We have a patient here who is hemodynamically unstable and is potentially receiving multiple pharmacological interventions. A paramedic who is able to monitor the vital signs and keep an eye on capnography is going to free up that treating clinician. Prior experience, knowledge, and appropriate communication skills are critical to ensuring that the patient's condition is identified. This links to earlier examples where shock may go unrecognized, as there is an overlap of some symptoms. Acknowledging concerns of attending crews allows for a comfortable environment that promotes communication and enhance decision making. Ultimately, a scene like this works towards improving patient safety. Thank you for taking the time to listen to my presentation.